You know, it's almost startling when you think about how often platelets, these tiny little things in our blood, are actually involved in blocking up our blood vessels.
Hmm.
It really makes you think about the drugs designed to deal with this, right? The antiplatelet agents.
Yeah, exactly.
But that's what we're really diving into today.
Right. And for this deep dive, we're going to try and unpack these antiplatelet agents.
Yeah.
Our main source here is the well-known Rutherford's vascular surgery and endovascular therapy.
Hmm.
We're focusing on the chapters covering these meds.
Okay.
The idea is to, go beyond just the names and really understand how they work, why they're used, their role in different vascular problems.
Sort of getting to the core of it.
Yeah, think of it as like a clear path to understanding a really important area of medicine.
Okay, let's unpack that then. So platelets, we know they stop bleeding from a cut, obviously, but it's more complicated than that. They're doing stuff all the time.
That's right. Normally, you've got about 150 to 350 billion of these cells per liter of blood circulating quietly.
Wow, that many.
Yeah. And they don't interact much because the lining of our blood vessels, the endothelium, keeps them calm. It releases things like nitric oxide, prostacyclin.
Ah.
It even has an enzyme, ADPase, that mops up ADP, which is a chemical that can get platelets excited.
And they don't live forever, right?
Nope. About 8 to 10 days is the average lifespan for a platelet.
So it's all pretty peaceful until something happens, like a vessel gets damaged.
Exactly.
Yeah.
That's the trigger. When a vessel wall is injured, the layers underneath the endothelium get exposed.
Okay.
Think of it like uncovering a sticky surface. It has molecules like tissue factor, collagen, von Willebrand factor.
Things platelets recognize.
Precisely. These molecules grab onto receptors on the platelet surface, causing them to stick. And this sticking, it triggers a big change in the platelet. It changes shape, and it releases two really key chemicals, ADP and Thromboxane A2.
Okay, ADP and Thromboxane A2, you said they're key. What exactly do they do once they're released?
Well, they're basically the amplifiers. ADP signals to nearby platelets, telling them to clump together. That's aggregation.
Right.
And thromboxane A2 does that too, but it also makes the blood vessel constrict, narrowing it, and it calls even more platelets to the scene.
So it's like a chain reaction, snowballing almost.
Yeah, exactly. More and more platelets piling on.
And then there's this other player you mentioned, glycoproteinibida. GPIIbu? What's its job in all this?
Yes. GPIIu. Think of that as the final connector, maybe the superglue. Once platelets are activated by ADP and thromboxane A2, these GPIIbu receptors on their surface become active.
Okay.
And what they do is grab onto fibrinogen, a protein floating around in the blood.
Fibrinogen.
Right. Fibrinogen acts like a bridge, linking one platelet to the next, making the clump really solid.
Forming the plug.
Exactly, the platelet plug. Then later, fibrin strands form and weave through it, making a stable clot. And the drugs we're talking about, the antiplatelets, they target different steps in this whole process.
Okay, that makes sense. Injury, activation, amplification with ADP and thromboxane, and then the GPIIa, locking it all together with fibrinogen. So let's get into the drugs. How do they interfere? Starting with thromboxane inhibitors, and obviously aspirin is the big one.
Yeah, aspirin is definitely the most common. Its mechanism is, pretty neat, actually. It's a non-selective inhibitor of cyclooxygenase, COX.
COX inhibitor.
Right. It mainly hits COX-1, and it does it irreversibly. It acetylates the enzyme, basically shutting down the production pathway for thromboxane A2.
So less thromboxane A2 means?
Less platelet aggregation. It dampens that amplification signal. And interestingly, at higher doses, it hits COX2 as well, which is where some of its anti-inflammatory effects come from.
Irreversible is key there, though, right? Once it hits COX1, that platelet's enzyme is out for good.
For the life of that platelet, yes. That's why even low doses have a lasting effect, despite, the known stomach issues.
Right. So when is aspirin actually used for this antiplatelet effect, and what kind of doses are we talking about?
It's really a standard for preventing secondary events. So if someone's already had a heart attack or has coronary artery disease, peripheral artery disease, stroke history, aspirin helps prevent another one.
Mm-hmm.
Primary prevention, using it in people without known disease, it's much more debated. No clear consensus there right now.
Okay.
Doses usually range from 75 to 325 milligrams a day.
And how fast does it work?
Depends on the type. Regular non-enteric coated aspirin starts working within about an hour.
Mm-hmm.
The coated kind takes longer, maybe 3 to 4 hours.
But if you need it fast?
Chewing, it helps. Gets it working in maybe 20 minutes.
Got it. Okay, so relatively quick, especially chewed. But you mentioned downsides, the stomach issues.
Yeah, that's the main one. GI side effects are common. Indigestion, gastritis, even ulcers or bleeding. The risk goes up if you have an H. pylori infection, for example.
And the bleeding risk itself.
Overall risk of a major bleed is maybe 1 to 3% per year. Higher if you're on other blood thinners, too. And while rare, true aspirin allergy can happen, causing things like bronchospasm, so you need caution in people with asthma or nasal polyps.
Makes sense. And managing it around surgery must be tricky. Balancing clotting versus bleeding?
It really is. For surgeries with a moderate to high bleeding risk, if the patient's heart risk isn't super high off aspirin, you might stop at 7 to 10 days before.
Okay.
But for low-risk procedures, or actually during vascular surgery itself, it's often continued. For carotid surgery, you'd even start it beforehand if they weren't already on it.
Interesting. Okay, let's move to the next group. Phenopyridines, ADP receptor antagonists. Clopidogrel is probably the best known one here.
Yes, Clopidogrel, often known by its brand name Clavix, it's what we call a prodrug.
Prodrug, meaning?
Meaning it's inactive when you take it. It has to be activated by the liver, specifically by enzymes in the CYP450 system, mainly one called CYP2C19.
Okay, so the liver switches it on.
Exactly. Once it's activated, it irreversibly blocks the P2Y12 receptor on platelets. This is a key receptor that ADP binds to. So block P2Y12, and ADP can't activate the platelet as well.
And because it needs activation, does that affect how well it works?
It can, yeah. The onset of action can vary. And crucially, people have genetic differences in those CYP450 enzymes, especially CYP2C19. Some variations mean you don't activate clopidogrel as efficiently.
Right, the clopidogrel resistance thing?
That's part of it, yes. The key things are that need for activation and the genetic variability. It affects effectiveness, and you have to watch for drug interactions.
Okay, so where is clopidogrel typically used?
A range of situations where you need to prevent clots, things like unstable angina, heart attacks, STEMI or NSTEMI, after a recent heart attack or stroke, or if someone has established peripheral artery disease. It's also used off-label after procedures like stenting coronary or peripheral or bypass surgery, and sometimes for carotid stenosis or someone just can't take aspirin.
What's the usual dose?
Standard dose is 75 milligrams once daily. But because of that activation step, it takes a couple of days to reach full effect.
So if you need it faster,
you use a loading dose, say 300 or even 600 milligrams. That can get significant platelet inhibition going in about 2 hours, which is important for procedures like stenting.
And side effects, similar to aspirin, bleeding risk.
Bleeding is definitely the main concern, yes. Can happen anywhere. Serious GI bleeds occur in maybe 2% of people. Less common things are itching or nosebleeds.
Okay. And surgery management, similar whole time?
Generally, yes. Stop at 7 to 10 days before elective surgery, minimum 5 days. The exception might be if someone has a very recent coronary stent and hasn't finished their recommended DAPT duration.
DAPT being dual antiplatelet therapy.
Right, usually aspirin plus something like clopidogrel.
You mentioned drug interactions earlier because of the liver activation, like with PPIs, proton pump inhibitors.
Yeah, that's a big one. Since clopidogrel needs CYP2C19 to get activated, drugs that inhibit that enzyme can potentially reduce how effective clopidogrel is.
And some common heartburn meds, the PPIs, do that?
Some of them do inhibit CYP2C19, yes, like omeprazole or esomeprazole. The clinical impact isn't totally clear for everyone, but the general advice is to try and avoid using them together if you can.
Okay. And let's circle back to that resistance idea. You mentioned genetic variations in CYP2C19.
Right. Some people have gene variants, alleles like CYP2C192 or 3. They mean they just don't metabolize clopidogrel into its active form very well.
So they get less drug effect?
Potentially, yes. Lower active drug levels may be a higher risk of clots or events. Other genes like ABCB1 and CYP3A4 might play a role too.
Can you test for this?
You can. Genetic tests exist, and there are also functional tests like Verify Now that measure how much the platelets are actually being inhibited after someone starts the drug.
So should everyone get tested?
Well, routine genetic testing isn't generally recommended right now. And even with the functional tests, a big trial called Gravitas looked at adjusting clopidogrel's doses based on those tests. It didn't show any benefit, didn't improve outcomes. So we can identify people who don't respond well, but just changing the dose based on that hasn't panned out consistently. It's complex.
Okay. Let's move on to another one in this class, Ticagrelor. How is it different from clopidogrel?
Ticagrelor, brand name Brilinta, takes a different tack. If Clopidogrel is like super glue on the P2Y12 receptor,
Irreversible,
right, Ticagrelor is more like a sticky note. It binds reversibly and non-competitively.
meaning it can come off again.
Exactly. So the level of platelet inhibition kind of goes up and down with the drug level in the blood. It doesn't need liver activation in the same way as Clopidogrel, but it is metabolized by the liver, mainly by CYP3A4 this time.
Okay. And where is Ticagrelor primarily used?
Its main indication is acute coronary syndrome, ACS. So heart attack, unstable angina. It's used to reduce the risk of cardiovascular death, another heart attack, stroke, and also clots forming inside stents in those ACS patients. Off-label, maybe for someone with unstable angina and STEMI who can't take aspirin. Usually starts with a loading dose, 180 milligrams. Then it's a maintenance dose, 60 or 90 milligrams, but twice a day because it's reversible and has a shorter effect.
Right, it needs more frequent dosing. How quick is its onset?
Pretty quick. Maximum effect in about 2 hours.
And side effects? Same bleeding risk.
Bleeding risk is generally similar to Clopidogrel, but Ticagrelor has a couple unique things. It can raise uric acid levels, so you need to be a bit careful in patients with gout.
Okay.
And some people get temporary shortness of breath, dyspnea, usually mild, often goes away within a week. Doesn't always mean you have to stop it.
Interesting. And surgery? Same whole time. Any big interactions?
Perioperative hold is similar, 7 to 10 days, minimum 5. For interactions, because it uses CYP3A4 for metabolism, strong inducers of CYP3A4 can be a problem.
Inducers meaning they speed up the metabolism.
Right. Things like certain barbiturates, some seizure meds like phenytoin, steroids, they could potentially lower Ticagrelor levels and reduce its effect. So caution combining those.
Got it. Okay, next up in the phenylpyridine group,
Prasugrel.
Efficient. What's its story?
Prasugrel is another prodrug like Clopidogrel. Needs CYP450 activation, and like Clopidogrel, it irreversibly blocks the P2Y12 receptor.
Okay, so similar mechanism to Clopidogrel, but maybe different activational potency.
Activation pathway is a bit different, generally considered more consistent and potent than the Clopidogrel. It's mainly indicated for ACS patients who are managed with PCI stenting. Can also be an option if someone can't take aspirin. But, and this is important, it's contraindicated, meaning should not be used in people with a history of stroke or TIA.
Why is that? Increased bleeding risk in the brain.
Exactly. Higher risk of intracranial bleeding was seen in those patients in the trials.
Okay, good to know. Dose.
Usual start is a 60 milligram loading dose, then 10 milligrams daily. Lower dose, 5 milligrams daily for people under 60 kilos. And it's generally not recommended for folks over 75, though may be considered in certain high-risk cases.
Side effects beyond bleeding.
Bleeding is the main one, of course. Others reported include high blood pressure, high cholesterol, and rarely that serious clotting disorder, TTP, thrombocytopenic purpura.
And surgery hold time.
Same pattern, 7 to 10 days before elective procedures.
Right. Okay, last one in this P2Y12, Cangrelor. This one's IV only, you said.
Yeah, Cangrelor is different. It's given intravenously. And like Ticagrelor, it binds reversibly to the P2Y12 receptor.
So, fast on, fast off.
Very much so. Its main use is during coronary interventions, like PCI, specifically in patients who haven't been pre-treated with an oral P2Y12 inhibitor, like Clopidogrel or Ticagrelor.
To bridge them through the procedure.
Sort of, yeah. To reduce the risk of clots forming during the PCI itself, periprocedural MI or stent thrombosis, even IV bolus dose right before the procedure, then run an infusion for at least 2 hours or the duration of the procedure.
And then switch to an oral one afterward.
Exactly. After the infusion stops, you transition them to Clopidogrel, Prasugrel, or Ticagrelor.
Side effects. Still mainly bleeding.
Bleeding is the main risk, but in the big trial, Champion Phoenix, the rate wasn't actually higher than with Clopidogrel used in that setting. Shortness of breath, dyspnea, was reported a bit more often with Cangrelor, though.
And because it's IV and short-acting, perioperative management is basically just stopping the infusion.
Pretty much. It starts working within minutes of the bolus. Very fast onset. And its half-life is incredibly short, just 3 to 6 minutes. Platelet function is usually back to normal within an hour of stopping the infusion. So it offers this very rapid but very temporary antiplatelet effect right when you need it during the procedure.
Okay, that covers the P2Y12s. Let's shift gears to another class. The glycoprotein IIIa inhibitors, also 5B drugs you mentioned.
Correct. These are potent inhibitors given intravenously. The main ones are Abciximab, RioPro, Eptifibatide, Integralin, and Tirofiban, Aggrastat.
And they target that final glue step we talked about?
Exactly. They block the GPIIa receptor itself, preventing it from binding fibrinogen. So they directly stop platelets from linking together, hitting that final common pathway of aggregation.
How do they differ? Abciximab sounds like an antibody.
It is. Abciximab is a monoclonal antibody fragment. Eptifibatide and Tirofiban are different. They're smaller synthetic molecules, peptide antagonists, that mimic part of fibrinogen to block the receptor.
Okay. And when are these powerful IV agents used? High-risk situations.
Generally, yes.
Oh.
High-risk situations, often around PCI. Abciximab is used during PCI or for unstable angiostenic patients heading for PCI to prevent clots. Eptifibatide is used in ECS patients whether they get PCI or are managed medically. Tirofiban is also for unstable angiostenic to reduce adverse events. They're all given as an IV bolus, then a continuous infusion.
And the big risk, given how strongly they block aggregation?
Bleeding. Definitely the major risk, especially if used with other antiplatelets or anticoagulants.
Any other specific side effects?
Abciximab can sometimes cause nausea, low blood pressure, chest pain. Eptifibatide may be hypotension. Tirofiban has rare reports of coronary artery dissection. And one notable thing for all of them is thrombocytopenia, low platelet count. It's more common with Abciximab, maybe up to 5% of patients, less with the others.
And managing them around surgery must need careful timing.
Absolutely. Abciximab binds very tightly and takes longer to wear off, even though its plasma half-life is short. You need to stop the infusion at least 12 hours before surgery.
Okay.
Eptifibatide and Tirofiban have much shorter half-lives, around 2 to 2.5 hours. They work fast, within minutes, but also wear off faster. Usually stopping them 2 to 4 hours before elective surgery is enough.
Right. Okay, let's move to phosphodiesterase inhibitors. Dipyridamole is one.
Persentine?
Yes. Dipyridamole works a bit differently. It inhibits enzymes, adenosine, deaminase, and phosphodiesterase. The net effect is you get more adenosine and more cyclic AMP or KMP inside the platelet and in vessel walls.
And what does that do?
Higher KMP tends to inhibit platelet aggregation, and both adenosine and KMP promote vasodilation, relaxing blood vessels. But on its own, dipyridamole is actually a pretty weak antiplatelet.
So why use it?
It's most often used in combination with aspirin. There's a specific combo pill called Agrinox.
Ah, Agrinox, for stroke prevention. Exactly. Agrinox is used for secondary stroke prevention. Also sometimes in symptomatic carotid stenosis, patients who aren't having surgery or stenting. Dipyridamole by itself is mainly used for cardiac stress testing. The 5E form dilates coronary arteries to mimic stress.
Okay. Side effects of dipyridamole or Agrinox?
Oral dipyridamole can cause headache, that's pretty dizziness, rash, GI upset. The IV form used for stress tests can sometimes worsen chest pain because of how it shunts blood flow or cause dizziness or headache. Needs caution in coronary disease. And for Agrinox, since it contains aspirin, the perioperative management usually follows the aspirin guidelines, potentially stopping 7–10 days before surgery, depending on bleeding risk. Dipyridamole itself has a half-life around 10–12 hours.
Okay. The other phosphodiesterase inhibitor mentioned is Cilostazol, Pleatal. What about that one?
Cilostazol is specifically a phosphodiesterase 3rd inhibitor. Like dipyridamole, it has vasodilator and antiplatelet effects. It might also help reduce smooth muscle cell growth in vessel walls, which could be relevant for restenosis.
And its main use?
Primarily for claudication leg pain with walking due to peripheral artery disease or PAD. It's shown to help people walk farther.
Okay.
There's also evidence it might help prevent restenosis after leg artery procedures like angioplasty or stenting in the femoropopliteal arteries, generally considered for PAD patients whose claudication doesn't improve enough with exercise and other meds.
How's its side effect profile?
Unfortunately, side effects are quite common and often lead people to stop taking it. Headaches, GI issues like diarrhea, dizziness, sometimes fast heartbeat, or palpitations.
Anything serious?
Yes, importantly, it's contraindicated in patients with heart failure. There's a concern about increased risk of serious ventricular arrhythmias.
Good to know. Surgery management.
General recommendation is to stop it 2–3 days before elective surgery. However, the bleeding risk with Cilostazol alone seems pretty low, less than 1%. So in some high-risk patients who need to be on dual antiplatelet therapy, it might be continued closer to surgery.
Right, balancing risks again. Okay, final class. Protease-activated receptor 1 inhibitors, PR1, Vorapaxar is the example. Zontivity.
Yes, Vorapaxar. This one targets a receptor called PR1, which is activated by thrombin. Thrombin is a really potent activator of platelets.
So Vorapaxar blocks thrombin's effect on platelets.
Exactly. It's a reversible antagonist of PR1, inhibiting that thrombin-induced aggregation. It takes about a week to reach full effect, and it has a long half-life, 3–4 days, so its effect lingers.
Where is it used?
It's indicated to reduce cardiovascular events, MI, stroke, CV, death, urgent revascularization, but specifically in patients who've already had a heart attack or who have established PAD. It's usually added on top of aspirin and/or clopidogrel.
So triple therapy sometimes.
Potentially, yes.
Yeah.
Or added to aspirin or clopidogrel if they're on monotherapy. The dose is 2.5 milligrams once daily.
Given it blocks thrombin activation, I imagine bleeding is the main concern.
Very much so. That's the major side effect. Clinical trials showed a significant increase in bleeding, including major bleeding and, worryingly, intracranial hemorrhage, ICH.
Bleeding in the brain.
Yes. Because of that risk, it's absolutely contraindicated in anyone with a prior history of stroke, TIA, or any intracranial bleeding.
Okay, that's a critical point. Any other side effects?
Less common ones can include anemia, depression, rash. There was another PAR1 drug, Abciximab, in development, but it was stopped due to similar bleeding concerns, plus liver enzyme issues and EKG changes.
Wow, okay. That's a lot of different mechanisms, a lot of different checks. This has been incredibly clear on how they work. Now, let's maybe pivot slightly and talk about how these are actually used in specific vascular diseases. Starting with trying to prevent cardiovascular death, stroke, MI, that primary prevention question with aspirin seems tricky.
It really is. As we touched on, the thinking has evolved. Earlier guidelines, like the 2012 CHEST ones, suggested low-dose aspirin might be okay for primary prevention in people over 50 without known disease, based on data showing fewer non-fatal heart attacks.
But that came with bleeding risk.
Right. And more recent analyses haven't shown a clear mortality benefit, just the reduction in non-fatal MIs, while the bleeding risk is definite. So broad recommendations for primary prevention are mostly gone now.
What do current guidelines say? Like AC?
The 2019 ACCA guidelines are more selective. They say low-dose aspirin might be considered for primary prevention, but only in specific adults, aged 40-70, who are at higher cardiovascular risk, but importantly, not at increased bleeding risk.
So very tailored.
Very. And they specifically say not for routine primary prevention in people over 70 or anyone at increased bleeding risk, regardless of age. It's a very individualized risk-benefit calculation.
Okay. But what about secondary prevention, someone who's already had an event?
Well, that's completely different. The evidence there is rock solid. Antiplatelet therapy significantly reduces the risk of having another event if you've already had an MI, stroke, TIA, etc.
So it's standard of care then?
Absolutely. Trials like Capri even showed clopidogrel might be slightly better than aspirin for that combined endpoint of stroke, MI, or vascular death in high-risk patients. And crucially, stopping aspirin suddenly, if you're taking it for secondary prevention, can actually increase your risk of a clopido, MI, stroke, stent thrombosis in the short term, like the first week or so.
So you need to be careful about stopping it.
Very careful, yes. Needs proper medical guidance.
Okay, let's move down the body. Peripheral artery disease, PAD. How are antiplatelets used there?
For PAD, guidelines like the 2017 ESC ones recommend antiplatelet monotherapy, usually aspirin or clopidogrel for pretty much everyone with symptomatic PAD, and even for asymptomatic disease in the legs or carotids, also after surgical bypasses.
What about after endovascular stuff like stents or angioplasty in the legs?
There, the recommendation is usually for dual antiplatelet therapy, DAPT aspirin plus clopidogrel, but typically just for 1 month, then back to monotherapy for life. And of course, lifestyle changes are absolutely key in PAD. There's some other evidence too. Adding Cilostazol might reduce restenosis after leg angioplasty. The TRA2P trial showed Vorapaxar reduced limb-related events in PAD patients.
Right.
And big trials like Voyager PAD and Compass looked at adding low-dose Rivaroxaban, an anticoagulant, to aspirin. They showed some benefit in reducing limb and cardiovascular events, but again, at the cost of more bleeding.
So lots of research ongoing.
Definitely. There's a trial called Long-DAP-PAD looking at longer DAP-PT after leg angioplasty right now. But, the main reason we use antiplatelets in PAD is still primarily to reduce the big cardiovascular risks, death, stroke, heart attack.
Got it. Okay, moving up to the neck, carotid artery disease. What's the role there?
Antiplatelets are vital for reducing stroke risk in patients with carotid stenosis, whether it's causing symptoms or not. Low-dose aspirin is effective. And starting aspirin early after a TIA or minor stroke is definitely beneficial. Some trials, like CRESS and CHANCE, actually showed that DAPT aspirin plus clopidogrel was better for acute secondary stroke prevention if the cause was symptomatic carotid stenosis.
What about after procedures? Carotid stenting or surgery?
For carotid stenting, while there aren't huge dedicated trials, the experience from coronary stenting and smaller studies suggests DAPT is beneficial. The Society for Vascular Surgery, SVS, recommends DAP, aspirin plus Clopidogrel usually, starting before the procedure and continuing for at least a month after, then lifelong aspirin.
And for carotid endarterectomy, the surgery.
For the surgery, SVS recommends continuing aspirin through the perioperative period and then lifelong afterwards.
Okay, that leads perfectly into the last big topic. Managing dual antiplatelet therapy, DAPT, around other surgeries, especially relevant for people with coronary stents.
Yeah, this is a huge practical issue. Patients with coronary artery disease, especially post-MI or post-stent, have very active platelets. DAPT is definitely better than aspirin alone for preventing further events in many of these patients.
So what are the rules if they need unrelated surgery? It depends on the stent type.
It does. And when the stent was placed. For older bare metal stents, BMS, the guidelines recommend at least 30 days of DAPT. Stopping before that significantly increases the risk of stent thrombosis, which can be catastrophic.
So delay elective surgery if possible.
Absolutely. If surgery is urgent within that first month, it's a tough call. You weigh bleeding risk versus clot risk, maybe continue just the aspirin if DAPT seems too risky for the surgery.
And for the newer drug-eluting stents, DES, the recommendations were longer day 2 initially.
They were. First-generation DES had concerns about late stent thrombosis, so 12 months of DAPT was the standard. But newer generation DES, the ones coated with everolimus or zotorolimus, have a much lower risk of this.
So the DAPT duration needed is shorter.
Generally, yes. The 2016 updated guidelines suggest delaying elective surgery for at least 3 months after a newer gen DS. If surgery is needed between 3 and 6 months post-DS, stopping the P2Y12 inhibitor part of DAPT might be considered, but there's still a slight thrombosis risk.
And after 6 months?
After 6 months with a newer DES, it's generally considered safe to stop the P2Y12 inhibitor for a procedure while continuing the aspirin if possible.
And always restart the DAPT afterwards.
Restart the P2Y12 inhibitor as soon as the surgical bleeding risk is low, absolutely. And aspirin should ideally be continued throughout if safe.
What if surgery is urgent or emergent before that recommended DAPT time is up?
That requires a serious discussion between cardiology, surgery, the patient, weighing the risks. People have tried things like platelet transfusions or IV bridging with drugs like Cangrelor or GPIIb inhibitors, but there's no guarantee they prevent stent thrombosis and they can increase bleeding. It's really challenging.
And what about long-term DAPT, beyond a year?
That's also been studied. The DAPT trial showed that going out to 30 months versus 12 months did reduce late stent thrombosis and major CV events, but again, increased bleeding. So for some very high-risk patients, longer DAPT might be considered, while for those with high bleeding risk, even shorter than standard durations might be appropriate. It's all about individualization.
Really highlights the balancing act. There are even algorithms to help with these decisions, right? Based on stent type timing?
Yes, flowcharts and algorithms exist to help guide clinicians through these complex perioperative DAPT scenarios.
Okay. This has been incredibly thorough. An amazing deep dive into antiplatelet agents. To wrap things up, what are the absolute key points you want listeners to take away?
I think the big things are: 1, understanding the crucial role platelets play, not just in stopping bleeding, but in causing vascular events. 2, recognizing there's a whole toolbox of antiplatelet drugs, each working differently. And 3, realizing that using these drugs is highly context dependent. Which drug, what dose, for how long. It all depends on the specific patient, their condition, their risks for both clotting and bleeding, and whether they're facing surgery. It's truly individualized medicine.
That's a perfect summary. It really drives home the complexity, but also the precision required. It makes you think, with new drugs and more research always coming out, how will we get even better at tailoring these therapies? Balancing those risks of clotting and bleeding even more effectively in the future.
That's the key question everyone's working on.
Absolutely. And if this discussion has sparked your interest in any particular area, definitely check out the source, Rutherford's, or look into the latest research. There's so much more detail out there.
For sure. Our aim today was really to give you a strong foundation. Empower you with the core knowledge without getting totally lost in the weeds. Understanding these principles is just so important for anyone interested in vascular health.
Well, thank you so much for breaking it all down for us, and thank you for joining us on this deep dive. We'll see you next time.